Hey guys, it's Olivia. Welcome back to your endocrinology chapter. In this section, we'll be going over primary adrenal insufficiency, which is a very commonly tested pathology on step 1. Primary adrenal insufficiency is going to occur at the level of our adrenal cortex. So if you look in this pathway over here, this is not a problem with your pituitary gland. It's not a problem with your hypothalamus. It is going to be a problem with your adrenal cortex, which means that everything that is responsible for stimulating the adrenal cortex, everything behind the adrenal glands or behind the blockage in this pathway, if you will, is going to build up because there's no negative inhibition. This negative inhibition is not happening when we have underactivity of our adrenal cortex. So we are going to get increased levels of adrenocorticotropin hormone. We are going to get increased levels of CRH as they are all attempting to stimulate the adrenal cortex to do its job, and the adrenal cortex just can't because it, of course, is insufficient. Understanding that will help us understand some of the pathophysiology of primary adrenal insufficiency. First, that this decreased adrenal gland function is going to result in a decreased level of all of the hormones that our adrenal cortex is responsible for making, such as aldosterone, that is a mineralocorticoid, or decreased cortisol, that is a glucocorticoid, and decreased androgens. Additionally, although all of these hormones produced by the adrenal cortex are going to be lower in the setting of primary adrenal insufficiency, anything that comes behind the adrenal cortex in this pathway is going to be elevated due to the fact that there's no negative feedback. So we have increased levels of ACTH. As we talked about earlier, the POMC gene is going to be responsible for encoding ACTH. The POMC gene, when it's transcribed, produces the protein adrenocorticotropic hormone, but the POMC gene also encodes for a lot of melanocyte-stimulating hormones. So, because the POMC gene encodes both our ACTH and MSH proteins, when we have elevated levels of ACTH, like in the setting of primary adrenal insufficiency, we are also going to see elevated levels of melanocyte-stimulating hormone. Melanocyte-stimulating hormone, exactly like the name sounds, stimulates melanocytes to produce more melanin. This increase in melanin production can lead to increased tan or copper skin if your patient is initially fair-skinned. This is why I have included this picture of JFK. JFK famously had this tan from sailing on his sailboat on the Atlantic that the media loved to rave about. This tan was, in all actuality, more likely due to the fact that JFK had Addison's disease and thus would have increased melanin even in winter, which is a funny historical fact that maybe speaks to the folly of American political rhetoric. Additionally, just as adrenocorticotropic hormone is building up behind the blockage of the adrenal cortex in this pathway, so is CRH. And CRH is a secretagogue of ADH or antidiuretic hormone. So when levels of CRH increase, this is also going to increase ADH secretion. A side note here, cortisol also opposes ADH secretion. So the perfect storm here when we have decreased cortisol production because of our insufficiency of the adrenal cortex, there's less opposition to ADH secretion, as well as increased CRH levels that are positively stimulating the release of ADH. This is going to lead to a significant increase in antidiuretic hormone release, which is another finding that you might see in primary adrenal insufficiency. Now, talking about the causes of primary adrenal insufficiency, there are many causes, but I basically like to think about anything that can hurt the adrenal cortex can cause primary adrenal insufficiency. So adrenalectomy, you completely remove the adrenal cortex. Autoimmune syndromes like polyglandular autoimmune syndromes, certainly if they are attacking the adrenal cortex, that can lead to adrenal insufficiency. Different infections that can affect the adrenal cortex like HIV, disseminated TB, or fungal infections. And then a very commonly tested infection, a result of Neisseria meningitis, is Waterhouse-Friderichsen syndrome. And this is basically Neisseria meningitis infects its host, it causes septicemia, and then this leads to adrenal hemorrhage. So a hemorrhage of your adrenal cortex could also cause adrenal insufficiency. DIC, again, if you're going to have damage to that adrenal cortex. Congenital adrenal hyperplasia. There are several different types of this that all have different hormones affected, and we'll talk about this in later videos. Low B5. B5 is important for your adrenal cortex and some of the hormones that it creates. And then infiltrative diseases such as amyloidosis or hemochromatosis, where we have some other material that is going to be displacing the cells of the adrenal cortex, could certainly lead to adrenal insufficiency. insufficiency. Finally, different drugs that decrease adrenal function like fluconazole, ketoconazole, or rifampin, these additionally could lead to adrenal insufficiency. So I know that's a lot to remember, but I think the big categories here are infection, different drugs that can cause adrenal insufficiency, and then infiltrative or hemorrhagic conditions. Now, a note about Addison's disease. Addison's disease is a chronic form of primary adrenal insufficiency. You can also have more acute forms, but when it's more chronic, it's called Addison's disease. Addison's disease is most commonly due to autoimmune conditions in the developed world, but it is most commonly due to TB in the developing world. So it's good to keep in mind where your patient lives when you are answering questions about adrenal insufficiency on step 1. Now, what are the symptoms of primary adrenal insufficiency? Well, the symptoms are going to relate back to all of the things that you are lacking in primary adrenal insufficiency. Because your cortex cannot make glucocorticoids, we are going to have a decrease in cortisol. Symptoms of low cortisol include weakness, fatigue, orthostatic hypotension. Remember, cortisol is important for your RAS system, muscle aches, sugar and salt cravings, weight loss, and GI symptoms. You also might see hypoglycemia as well. Cortisol does have an important role in regulating glucose in the bloodstream. Additionally, you're going to see some mineralocorticoid symptoms. So because you have decreased mineralocorticoids such as aldosterone, you could see a type 4 renal tubular acidosis. Remember, this is going to be a hyperkalemic, hyperchloremic, non-anion gap metabolic acidosis. And with that, you could see all of the symptoms of hyperkalemia because you have increased potassium being retained since we are not activating that sodium-potassium exchanger as much in our distal tubules and collecting duct. Symptoms of hyperkalemia include heart palpitations, chest pain, nausea, emesis. Remember, potassium is important for the membrane potential of our cardiac myocytes, so it can also lead to some very dangerous arrhythmias. Additionally, we're going to have symptoms of decreased androgens. These are going to be a little bit different depending on if our patient is male or female. Both can experience depressed mood, decreased energy, decreased concentration. Decreased androgens usually present as irregular menses in females and erectile dysfunction in males. And then skin hyperpigmentation. Remember JFK over here with the permatan. This skin hyperpigmentation is going to be related to the fact that POMC gene is going to be responsible for encoding both ACTH and melanocyte stimulating hormone. And we have more melanocyte stimulating hormone that leads to more melanin, which leads to the skin hyperpigmentation. Finally, you also may see levels of elevated antidiuretic hormone. This, in conjunction with the fact that you might have decreased aldosterone, can lead to hyponatremia. Hyponatremia symptoms include seizure, nausea, emesis, headache, confusion, muscle cramps. So if you see this in a presentation of someone who has primary adrenal insufficiency, you should definitely be concerned that they have hyponatremia, either due to the fact that they have too much antidiuretic hormone, so they're retaining water and diluting the salt they already have, or they have too little aldosterone, so they are not saving enough sodium and all their sodium is getting excreted in their urine. And then one final note on the presentation of primary adrenal insufficiency. Primary adrenal insufficiency is often associated with autoimmune polyglandular syndromes. So look out for problems with other organs in the endocrine system if you see someone with primary adrenal insufficiency, especially if it's autoimmune. Now, the diagnostics for primary adrenal insufficiency, I think, are pretty easy to figure out if you just keep in mind this pathway over here. So we're going to have decreased cortisol. That's pretty obvious. Primary adrenal insufficiency means we are not making enough of the hormones made by the adrenal cortex, one of which is cortisol. We're going to have an increase in ACTH. That makes sense as well. ACTH is building up because we have a blockage right at the adrenal cortex, so everything behind it in the pathway is building up. We're going to see decreases in aldosterone. We have decreased mineralocorticoids, again made by the adrenal cortex. We're going to see an increase in potassium. This makes sense, right? Because we have a decrease in aldosterone, which means that we are not excreting as much potassium into our lumen. That potassium is being retained inside the body, so we are going to have a buildup in potassium. We're going to have a decrease in glucose. That makes sense. Cortisol is responsible for maintaining glucose levels in the blood, so when we don't have it, we can certainly get hypoglycemic. And then a quick note on blood work in patients that have primary adrenal insufficiency. You might see elevated IgE or eosinophil levels, and this for me was a very important fact to know for step 1, so I've included it here on your slide, as well as a high yield button, because all of these diagnostics are very high yield for step 1, but this IgE and eosinophil increase was something that I definitely got asked about on rounds. Continuing to work through these diagnostics, diagnostics, your morning cortisol levels are going to be decreased. Our morning ACTH levels are going to be increased. Once again, build up behind the blockage at the adrenal cortex. And then our ACTH stimulation test is going to have no response. And that should make sense to you if you understand that because of any of these etiologies, our adrenal cortex is infarcted, or it's infected, or it has an infiltrative disease. The adrenal cortex just physically is not able to make these hormones. So it doesn't matter how much ACTH you pump into the body and tell it to do its job. It's not doing its job because it physically can't. And that is why we are not going to see any response here in primary adrenal insufficiency with our ACTH stimulation test. Finally, management of primary adrenal insufficiency is just replacement of all of the hormones that our adrenal cortex should be making. So you are going to need to replace their mineralocorticoids, you're going to need to replace their glucocorticoids, and replace their androgens since they are not making these on their own. Okay, I know that was a lot of information. Let's quickly recap what we talked about. Your classic patient with primary adrenal insufficiency is going to be a patient that has JFK's copper-toned skin. They are going to be low weight. They're going to have fatigue, orthostatic hypotension. They may present with these hyponatremia symptoms, or they may present with symptoms of hyperkalemia. On labs, you're going to see decreased AM cortisol, increased ACTH, and no response to our ACTH stimulation test. And then one way they might ask you about this on a board style question is something like, a 55-year-old woman presents to her primary doctor for 6 months of irregular menses and dizziness when she stands up from a chair. For the past 2 days, she has also been experiencing nausea, emesis, and her husband states that she has become increasingly confused. Labs reveal elevated IgE levels, elevated ACTH, and hyponatremia. What is the most likely value of her urine sodium? Okay, so we're getting a picture of a 55-year-old woman. She has fatigue. She has this dizziness when she stands up from a chair. Could definitely be orthostatic hypotension. They tell us that she has hyponatremia, and in addition, she also has irregular menses. But there still could be a lot of things causing this. One of the very important clues that they gave you here is that she has elevated IgE levels in addition to elevated ACTH. Both of these clues should lead you down the road of primary adrenal insufficiency, and the question asks you, what is the most likely value of her urine sodium? Now we know that our patient has hyponatremia in the setting of adrenal insufficiency. Hyponatremia in the setting of adrenal insufficiency is most likely caused by increased ADH or decreased aldosterone. And if we think about what's going on in both of these pathologies, antidiuretic hormone can turn off the RAS system. Aldosterone is an important part of the RAS system, so if we don't have enough of it, then our RAS is certainly decreased. We get a picture of decreased RAS activation. As I talked about in my hyponatremia video, when you have decreased RAS activation, this means that you are going to have increased sodium excretion, meaning there's more sodium in your urine. Now, the general marker for increased urine sodium is around 20 or 30, so that is the answer I'd be looking for on step 1. Now, that's all I have for you on primary adrenal insufficiency. I hope this video was helpful, and I'll see you next time.